Hi and welcome. I'm Dr. Robert Glatter, a member of the Medscape Emergency Medicine Editorial Board. Joining me today to discuss the new Max docuseries, The Pit, a depiction of daily struggles and realities of life in a busy Level 1 trauma center, are Dr. Amy Ho, an emergency physician and member of the Medscape Emergency Medicine Editorial Board, Dr. Nicholas Cozzi, an emergency physician and medical director, EMS and disaster medicine at Rush University Medical Center in Chicago, and finally, Dr. Mel Herbert, also an emergency physician and founder of a popular educational podcast known as MRAP, a lifelong educator and medical consultant for the Pitt, as well as ER from the early 1990s that we all remember. Welcome, everyone.
Thanks for
Awesome
having
to
us.
be here.
Thank you.
Yeah, it's great to have everyone here. Pitt, in my opinion, is one of the most influential and powerful series. It's so unique in that each episode is represented by 1 hour of an ED shift. And that differentiates it from other past medical docudramas that you may have seen, such as ER. In reality, we know that an hour really passes quite quickly in any given shift. The show truly, in my opinion, encapsulates the stressful clinical scenarios and interpersonal relationships that occur in any given ED shift. And it certainly resonated with me and my colleagues. Mel, I wanted to get your feedback on how you chose to proceed with advising directors and producers on the show to provide real-world scenarios that could inform the audience, as well as emergency physicians, obviously, how we manage complex situations, specifically families, bystanders, but also accurately depict how residents interact with other residents and attending physicians.
Yeah, well, first of all, thanks for having me on the show. The Pit has obviously become this huge hit, more than anybody, even we expected. But I have to give credit where credit is due. So Scott Gimel is the show creator and the showrunner, and it was his idea to come up with this hourly format. He met with John Wells, the producer who did ER, and John was very clear. It's like, we don't want to do just another medical TV show. We want to do the best one. How do we make it the best? How do we make it different? How do we make it real, but also entertaining? And that's when Scott came up with this idea of, 1 hour of the show would be 1 hour of a shift. It was an incredibly insightful idea. And then the next person is Joe Sachs. Joe Sachs is an emergency physician. He's been practicing for 35 years. He was the medical writer on ER, and he brought me in the last 6 seasons of ER as a consultant. And then about 2 years ago, a year and a half ago, Joe said, "Well, we're going to do this new show. I think it's going to be fantastic. Do you want to be a consultant again?" I'm like, "Absolutely." So in that first season, I was a consultant, and that basically meant that Joe would contact me multiple times a week, sometimes multiple times a day, and we'd go over cases and talk about how would this case really work out and what would be the dialogue between the physicians, and just run sort of stuff by me. And then for the second season, it's like, "That's great, Mel, but now I need you in the writer's room." So for season 2, I'm actually a staff writer and consultant with Joe. And that's been an incredibly fun experience. I've never really done in this level, to be sitting there with the writers and actually from day one going through all of the cases. But the key thing is to make it accurate. That's what we want to do. You can never be 100% accurate because it is still television. But I think we're making it as accurate as possible, and the docs and the nurses and everybody love it. And a lot of them say, "I can't watch it. It's too accurate."
Right. I think a lot of people are triggered by it. And a lot of my colleagues have talked about this, that when they actually watch it, they feel like they're in it, so to speak. Nick, let me bring you into this. Your article in Time really was an excellent summary of the experience of so many of us. And you explain it as cathartic. And I was hoping you could explain the catharsis to the audience and really your thesis of your Time magazine article.
Sure. Well, thank you very much for the opportunity to be here, Mel. Congratulations and great job on everything you've done along with Joe Sachs on the Pit. Time Magazine approached us with that thesis of, we hear it's too triggering for emergency physicians to watch the Pit, that they feel as though they are back at work, they are in the department, and they don't want to watch it. And not just emergency physicians, but anybody who works in the ER. And so Dr. Cozzi, they asked, "Do you agree with that?" And I said, no. Just because it's stressful and because it depicts what is actually happening, should not avert our gaze. We shouldn't shield our eyes. We need the entire healthcare system and the entire country's eyes on what is actually happening, the brokenness of our healthcare system, and how emergency physicians and those who work in the ER each and every day are dealing with this struggle. And so that's where Time really understood what we were trying to do. But I think more than anything, Mel, than being accurate on a medical diagnosis, you pulled the curtain back and showed what's happening with hospital boarding. You pulled the curtain back to show what's happening with patients in the waiting room, with patients in the hallway, loved ones and members of their family. What we tried to do with the Time article was provide a way for the lay public to understand hospital boarding, to understand that it's not indifference from emergency teams, but it's the healthcare system pushing down on too few shoulders. So thank you, Mel, and it's a pleasure to be with you.
And Amy, I wanted to bring you into this and get your viewpoint of how the show impacted you and your colleagues. Did you feel that you were in it, so to speak, as you watched the episodes?
I think so, but I feel what Nick said and obviously what Mel said about it being so medically accurate. But to me, the pieces that tug at your heartstrings is not the medical accuracy. Like, to be honest, I got inspired to ultrasound more because I'm like, they ultrasound everything. I'm like, I should ultrasound more. But the parts that get me and get my colleagues and get a lot of women, especially in medicine, are the humanist pieces. Well, I don't think this is a big spoiler, but there's a miscarriage of a physician on shift. And the response that had from women who had the exact same experience, went to the bathroom, miscarried, popped back out, saw more patients, was something that was so true and not talked about. And it's those pieces of what makes emergency medicine special and what makes it hard that we don't talk about, that the Pit brought out and really gave us a little bit of just feeling like we were seen. The pediatric death, I think, was another incredible example of that. And, Mel, I have to say, I'm a big fan of what you do on MRAP also. And you say on MRAP all the time, what you do matters. And what the Pit did was it did an incredible storytelling of exactly that, of what you do matters.
The storytelling is just so impactful. It really resonated with me to the point where you can't stop watching it. You go episode to episode because it's that, hour to hourly transition that you want to know what happens next. I do want to quote one of the paragraphs that Nick wrote in his piece. I think it resonates with me and hopefully others. For an emergency medicine physician, a typical shift is a front row seat to the worst day of people's lives, a whirlwind of drama, frustration, quiet victories, devastating losses, and unfiltered humanity. And then it's on to the next patient's room to do it all over again. That really resonated with me. And we do it all again because that's our training. We're tired, we're fatigued, we're hungry, but we move on to the next patient. We're dedicated. And really, I want to commend you on this piece because after watching the show and then reading your piece, it just really made complete sense.
Thank you very much. And I've heard from physicians around the country, those in healthcare that, like Amy said, feeling seen in a way that I think the Pit depicts. And if my piece helps with individuals feeling that, it's a great honor. When I think about Noah Wiley, for example, and how being a star as John Carter in the 1990s ER, and now the burnished, seasoned attending physician later on in his career on the Pit as Dr. Robbie, I think of the transition we're all making in our own lives, whether we were practicing back then or now we're taking on the next step of our journey. But I think one of the things that people who saw the show in the 1990s ER and now are watching the Pit, they see somebody making that full circle in his own life, teaching, training, communicating, but not being afraid of showing emotion and being a human being in unrealized or unimaginable situations. Amy, you brought up the loss of a child, dealing with a pandemic, everything that I think MRAP, for example, Mel, did during COVID for emergency physicians, that not triggering, but in a way that cathartic environment of as emergency clinicians feeling seen. So I think in a way, Noah Wiley has come full circle in his role as an emergency physician, but also never losing that sight of not only optimism, realism, but being able to be a human being in unimaginable situations.
And Mel, I'll commend you. Dr. Robbie's character is so well developed that, he's just on the brink every time, like about to just break down. He goes into the room, he's crying. He needs another resident to kind of pick him up. And that to me is emblematic of, the system and where we're at. and that, the emotional weight of what we deal with on a daily basis impacts us. And Nick's article points to that fact. And the character development was very important here. I obviously assume that you made that clear to the directors and producers.
Well, again, I have to give real props to Joe Sachs, who he's really the guy when it comes to the medical stuff. But Noel Wiley, he's first of all one of the nicest human beings you'll ever meet. He is just a good person, and he cares deeply about emergency medicine. And his arc as an actor was the most important thing he ever did was be on ER. And he's had physicians over the years come up and say, "I became a doctor because of you. I became a nurse because of you." And he really wanted to come back because people were coming to him, physicians, nurses were coming and saying, "We're in trouble. Emergency medicine's in trouble. We're burning out. People are dying. And could you come back?" And so that's when he got together with John Wells and Scott Gemmell and Joe to say, "Let's do this again. Let's do it right." And they really wanted to depict what's it really like, not like other TV shows, but what's really happening, the boarding crisis, the stress, COVID, the burnout that physicians are feeling, and the systems issues. And they wanted to make that real. And Noah is such an incredible actor now. He was a pretty good actor back in ER. He is now the full professor of emergency medicine acting. He's so good. And when you see that scene where he loses it, I think every emergency physician, myself included, have been there and just like, oh my God, that's me. And so this theme we keep hearing, which is for the first time emergency physicians feel like they're being seen, is one of the most gratifying things. Family members can now look at the show and know what dad or mom does for a living for the first time.
So, Amy, I want to ask you, as residents and medical students looking at the show, do you think in some ways it might turn them away? I mean, the match this year was very productive, but when you look at a show like this that depicts emergency medicine and what we deal with, obviously there's positives and negatives with any specialty, but do you feel that it has the potential to scare away some very promising residents and medical students?
I think that's a great question. I mean, I'm a millennial. I was a little bit too young to catch ER, and there were really no shows until The Pit that I think were as accurate. So to me, I think The Pit will have the effect that ER did, which is actually get people more interested in emergency medicine because you see what's really great about it. And of course, you see the downsides of it. But I think it sparks something in us that is what attracts us to emergency medicine, which is that we want to make a change for the patient that is so vulnerable in front of us that we're helping, but we also want to make a change for the system, which is oftentimes why we get so frustrated. So I think The Pit will help really captivate the right people to go into emergency medicine and in a lot of ways show an incredibly honest depiction for people who maybe thought they wanted to go to emergency medicine and didn't. And Rob, you and I have talked about this on Medscape before. I think one of the biggest reasons for people leaving emergency medicine is because the field isn't what they thought it was. And I think The Pit actually helps give you a really honest story of what you're getting into and that it's incredible. And yes, it's hard at times, but you can make a difference.
Right, it's dedication. And I think Walter O'Donnell in his 2022 article in the New England Journal talks about administrative harm, the systemic issues. So addressing administrative burden is certainly relevant here. And the show opens up, the whole hornet's nest on what really is going on. A broken system, Nick, that you write about, the boarding crisis, the shortage of nurses, things that have to be addressed that are still not being addressed. When I started practicing, these issues were there. They still have not been handled. So the question is, why isn't there a larger movement to address the systemic issues so that personally individuals can survive? How do we fix this broken system? What is the real key to finally gaining traction?
It's an excellent question. And I think a lot about the most common question people are asking me about The Pit. It's not, can you really do a burr hole with an IO? Can you do that type of procedure? Is that accurate in terms of a cardiac arrest? What they're asking me more often than not is that what it's really like trying to save someone's life and a hospital administrator is asking you about patient satisfaction scores? Is that what it's really like when you try to take care of a patient and there's no beds upstairs that have nursing staff assigned to them? And that to me is fascinating because that's the first step is getting the general public to understand beyond the resuscitations, beyond the complex saving lives, it's making seen what is very complex and has been behind the barrier. When patients come to our ER, as Amy, as you, as Mel know, and they see that 14-hour wait and they don't understand, they think it's indifference. They believe it's because we're not taking care of them. But this is tried to unlock that door so people could see the systemic issues that for a long time have been behind the curtain. I think that's the first step, is the public understanding how broken this all is, the mismatch of finance, the mismatch of allocation, the value-based system that we're not having right now. So how do you have a complex conversation about hospital boarding that isn't throwing facts at people, but in a way of putting yourself in that position if you're the family member with your loved one in the hallway and you're not seeing them being taken care of? That's the first step. And that's what I think the Pit does differently than any other show, is they're talking about those issues, staffing, nursing shortages, boarding crisis, in a way that's palatable and can be received by the general non-medical public.
So, Amy, let me ask you, on a congressional level, is there any way to address what Nick is pointing to, that there needs to be systemic change, legislative changes, not just at the state level, but really at the national level?
Yeah, absolutely. I think Nick makes a really good point that the first step is absolutely to educate. Educate yourselves, educate voters, educate patients, educate anyone in the healthcare system, which is really all citizens. And I think the second step is advocate. I mean, we have multiple, national organizations. There's the AMA, there's ASAP, and most of them are very involved in the boarding crisis. There's a boarding summit. Multiple states have actually passed various legislation about boarding and wait times in emergency departments. There is always discussion on, of course, Medicare reimbursement. There's always discussion on value-based programs, including MIPS, like which ones matter, which ones are just administrative burden. There's a lot of national healthcare safety scores like Leapfrog, which is really incentivizing for hospitals to address. I think all of these are avenues to advocate. You can advocate by voting. You can advocate by getting involved with your organization. You can advocate by just speaking. This is the age of social media where you can talk about that. But we're starting to see changes. The National Boarding Summit had multiple very discrete recommendations. Leapfrog, which is again one of the national safety ratings for hospitals, just added ER boarding onto one of the tenets that they're trying to get data on to help rank hospitals. So we're seeing a move because people are getting educated and then advocating.
And Mel, since you're so intimately involved in this show, have you seen any changes as a result of your national involvement in a show that's become such an impactful type of experience for not just physicians, but for the public?
I think the answer to that is yes, because of this. What's happening right now? Noah and Joe and me, and we are constantly trying to write, and in between those writing, we're talking to people across the country, across the world. I think it's really elevated this discussion, and that's the most important thing. We are not saying what the solution is. There's people with degrees in this need to come up with these solutions, but if we can sort of show exactly what it's like, how bad it is, how close it is to falling off the cliff, then maybe people like Amy can help us push it across the line. We don't have the solutions, but we can tell you what the problems look like. I was just interviewing Al Sacchetti, Dave Schreiger, Peter Viccellio, three sort of legends in our field, and they had very different ideas about what to do. There were some of them that were saying we should go on strike. The only way this is going to get fixed is if we make a crisis and we fix it. And there were other guys like Al Sacchetti's like, I can't do that. I have to look after the patients. I can't not be there and do this. And that's part of the problem, is that ER docs will always try and fix the problem. We will always go into the waiting room and try and go as fast as we can to help people. But that is actually not going to fix the system. We need somebody from outside to say, you're going as fast as you can. We need to get you help. And if we can use this show to tell those stories in Congress or wherever it needs to be, have at it.
One thing I do want to focus on is violence against healthcare workers. And obviously the scene where the charge nurse, she gets punched in the face by a patient who had basically retaliated for a long waiting time. That resonated with so many of us because it's happened where I've worked and many places I'm sure where many of you have worked. How did you set that scene on, Mel? Like, what was in your mind and how did you approach it?
Well, again, all to Joe. Now, you need to know that Joe was my attending at UCLA when I first got off the boat from Australia. So, I love Joe. But again, it was him and the writers sitting around like, what are the issues? And workplace violence was one of the top issues to talk about. There was just a study that came out that for ER nurses, about once every 3 shifts, there is violence against them, verbal or physical. And I think it's about 3 times a shift, depending on how you define it. It's really a problem. During COVID, it became worse. There was this weird thing where people will stop believing in science, stop believing in doctors. But then when they were critical, they would come in and ask for their ivermectin and would be outraged when you said, like, that doesn't work. Let's try and help you with stuff that does work. It has become just an epidemic. It was always bad in emergency medicine. As Nicholas pointed out, like, we get to see people on their worst day. We get to see all of the problems of society get filtered to the emergency department. And violence is a big problem in this country, as it is in many countries. And guess where that all comes to? It comes to the emergency department, and it is often then displayed against emergency physicians and nurses and everybody that works there. It is a crisis. And I got an email recently from somebody saying, please be careful about how you depict this because we don't want people to think this is normal or it should be acceptable. Unfortunately, it is normal. It is not acceptable.
Absolutely. It is not acceptable. We can't normalize it, but we have to depict it. Unless you show the public what's truly going on, they won't understand. And so as physicians, emergency physicians, we get it, and we have to put a stop to this. Legally, I believe it is a felony for attacking a healthcare worker. Is that correct? No, are you aware
It's
of
by
this?
state. Arizona has a very strong rule. One of the things that we do on the Pitt is we bring in experts and talk to the writers within the writers' room. And there is legislation in Arizona, for example. I don't know exactly what level. Before this legislation passed, you got in more trouble for kicking the neighbor's dog than by punching the ER nurse, like literally. So in Arizona, they've passed these laws, and there are many more laws in other states that are working their way through the system, which, as we all know, is quite slow. But we need things like that. It needs to be very clear. Just because you're pissed off and you're angry and you've waited a long time, violence is no way to get this fixed. And you could be in big trouble if you pursue that.
Absolutely. So Nick, in your ED, are you seeing quite a bit of violence against healthcare workers?
Every day, whether it's physical violence or the violence that, as Mel eloquently stated, is happening, perhaps gender-specific differences, with females being more likely to experience that violence, suggested comments, things of that nature that are being underreported. And I think Mel answering that person's letter that it is normal but not acceptable is absolutely the right solution. I think back to Time magazine in the early 1990s. They had a cover article that said ED is at the brink. And we're in 2025 and the ED is still at the brink, but it's worsened because of the social issues that we're talking about. But healthcare workers and those in the emergency department did not choose law enforcement. No one should feel unsafe going to work every day, that their lives are in trouble going. We had an emergency physician in Chicago that got stabbed in the chest during a patient encounter a few months ago. Luckily, he survived, and I understand he's doing well. But that's just one story of so many. We see it every week, every day around this country. There has to be an opportunity, and I'm very thankful that the airline industry has found the opportunities to understand what violence happening on airplanes or in airports and how those individuals are being dealt with in a very, very firm fashion. If we're bound by EMTALA, a federal mandate to evaluate anybody who walks through our doors, that there should be federal things on our books to be able to protect our workers, with caveats for those who do not have medical decision-making capacity, those experiencing crisis in different ways. But we have to find unique solutions. And this is one of the areas, Mel, that I think is different than the early 1990s because of the way society perhaps has caught up. We can't waste this moment that you and Joe and Noah have provided us at this time.
Yeah, I agree with that. Amy, any thoughts want to add to that?
I think absolutely workplace violence is a huge problem, extremely common, rampantly underreported. Luckily, in the majority of states, actually a felony or otherwise having some kind of zero tolerance law. So an instance where advocacy has really worked. But I think the piece that the pit really helps with is people are angry because they've been waiting. They think the charge nurse, they think the attending, they think, whichever staff member is representative of that and part of that. And what the pit does really beautifully is actually it divorces the staff who are just as frustrated from, this concept of the system. Like I've already had patients since the pit came out that I see in the ER and they'll be in the hallway and they will tell me like, wow, this is just like the pit. And they mean it positively. And they are in a hallway bed and they kind of understand why in a way. Like they're not mad at me, which is this change that I've really seen since the show comes out. That's been just an incredible testament to what it means for not only us in the field, but also for lay people in understanding what is healthcare today.
One last thing I do want to discuss is how residents relate to other residents. And this was depicted in the show, showing toxicity, microaggressions, things that certainly got tolerated. But, this is an area I think that was well documented in the show, Mel, and certainly is something that's so important to highlight.
Yeah, residency's hard. You just think about these poor young adults who have gone through high school and then achieved at the highest level. And then they go through college, achieve at the highest level, then go through med school, achieve at the highest level, and then have hundreds of thousands of dollars worth of debt, and then do residency and they're sleep deprived and they're shifting from days to nights. It's a very, very difficult job. Trying to depict that is really important. My experience, though, is that residents are really good to each other. In general, overwhelmingly really good to each other. There are some that sort of crack, and when you see that resident that's really, having these microaggressions towards other residents, your first thought should not be that this is a bad person. Your first thought should be this person's struggling. How do we help them? Because it is a very difficult thing. At LA County years ago, we did sort of a snap survey of over 60 residents. 30% of them had suicidal ideation in the last month. Just think about that. 30% of them. It's a tough job, and I think residency directors are much better now than they used to be about understanding the mental health of the residents and being much more in tune with it. And I hope that comes through in season 2.
Oh, absolutely. Looking forward to that. Amy and Nick, I want to get your thoughts about mental health and your EDs and how, that's approached. And is there an acute awareness as Mel is describing?
I think every person that goes into emergency medicine, just like any person, has their own demons. And what emergency medicine forces you to do is it not only puts you in a pressure cooker just by the setting and, the time issues and a lot of the frustrations, but a lot of times it puts you face to face with some of your own weaknesses, some of your own fears. It's very obvious, in the show when a resident is triggered by something that she clearly experienced in her own life. And now a patient is reflecting back to her something that she herself had been extremely traumatized by. So I think we all have that. And one of the most interesting things to me is we also all develop a callus to it. And in order to be able to move on from, a devastating trauma in a room into, a low acuity knee sprain or something and put on a happy face and think about patient satisfaction. Our ability to task switch like that and emotionally task switch like that is very unnatural. It's a defense mechanism we come up with, which means that when we leave shift, a lot of times we take that emotional whiplash and we just put it aside. As Nick was saying, maybe this is why people can't watch it. But in a lot of ways, I think what's best for us is to stop, to reflect, to think about it, to, kind of honor the feelings that you had in that moment, even though you had to put them aside so you keep working, but to come back and honor those feelings so that you can process them and realize that being a person and being human is what also makes you a great doctor. So don't get rid of that. And you see that with so many of the characters in the pit in a way that is just so beautifully written, because in different various stages of my life, of my training, I have experienced those exact same iterations that the different characters go through.
I remember when Damar Hamlin had a cardiac arrest on the field in the Buffalo Bills, and 50,000 people saw him in cardiac arrest, and the excellent display of medical teamwork and communication ultimately saved his life. We talked a lot about the psychological impact of every one of those individuals in the stands, and we're not minimizing that. What they saw was a traumatic event. But like Amy eloquently discussed, that's something that happens every day, and the ability to task switch is a defense mechanism. but there's still opportunities for us to do much more when it comes to mental health. We're still looked at as superheroes, but we're not. We're human beings. We bring our own issues into work every day, struggles with our spouse, difficulties with our own children that are traumatizing to us in and of itself. Secondly, there's still areas around the country for credentialing that are mistreating emergency physicians as it relates to mental health struggles, being on prescription medication. And we have to make that okay. We can't make emergency physicians want to hide the humanity of their own lives because they feel ashamed about it. That's part of the problem. I would wonder, Mel, what we would do right now if we asked emergency physicians in training or even those practicing what the rates of self-harm, suicidal ideation, or just overall fatigue as it relates to dealing in this own crisis and having your own issues and having to hide them. So we have to do more work.
I can tell you that every emergency physician I talk to, and I talk to a lot of them, is burnt out, is feeling the struggle, has moral injury. I've talked a lot about the fact that I developed severe depression, suicidality at the end of my career and had to get ketamine, and it really helped. When I talk about that, I don't like to talk about it because of my position. I feel like I need to talk about it. I can't tell you when I go to ASAP, I get overwhelmed with people saying, thank you for talking about that. I have the same thing. I need to get help. I think that it's so under-recognized. We don't want to talk about it. We're supposed to be superhuman, but we are not. I was talking to the Laura Breen Foundation yesterday. Laura Breen, as many as you know, was an ER doc, the head of her department, who died by suicide at the beginning of COVID because she couldn't cope. And we talked about the fact that ER docs have this backpack, and we throw these things into the backpack. Oh, dead baby, let's just throw that in the backpack. Oh, a 32-year-old woman dying of cancer, let's just throw that in the backpack. If you don't unpack that thing, it will catch up with you. Nobody gets away from this. And I think for a lot of us, like for my generation, you just chuck it in the backpack. Let's not deal with that. It will catch up with you. I honestly believe that every ER doc, every ER nurse should be in some form of therapy for the duration of their career, from day one until it's over, and then for 5 years afterwards. Because this is not a normal job. It's not normal.
Right. Therapy is so critical. It's not just debrief or a huddle after a difficult case. It goes deeper. And I agree with you, Mel. Therapy should be something that is almost required because of the nature of the work we do. We have to be able to talk about it and to at least describe our struggles. I appreciate, obviously, you sharing with our audience your personal journey and struggles, because that resonates. It resonates with all of us. And I really, really, truly appreciate that.
Yeah, well, it's really important to me. This is sort of the most important thing to me right now. I see so many ER docs struggling, and I don't know an ER doc that doesn't have a dead baby story. I, for years, still can see the faces of the kids that have died on my shift. Even now, you can hear it. It doesn't go away. You just got to learn to cope with it and get help if you need it. We're all the same. We have all got this experience. If we all get therapy, and this is a really important point, if it's mandatory that we're all in therapy and we're all getting help, guess what? Stigma's gone. Because even if you're mandated to write something about that on your credentialing, if we all do it, we're done.
I wanted to thank everyone for a very impactful and very insightful discussion. These topics are obviously so important to emergency physicians, and they resonate. The show is such an important teaching tool, in my opinion. Season 2, I'm looking forward to seeing what struggles and what events happen, because based on season 1, it really will provide a real good springboard to go forward. Any other final thoughts?
I got one to tell you. I'm very excited to tell you that Noah Wiley and Joe Sachs are coming to ASAP, and we're going to do a little panel after the keynote where we'll take questions from the audience, and then Noah's going to walk around a little bit in the sort of trade area, but it'll be an opportunity for people to talk to the real geniuses behind the show in Noah and Joe, and there's many others. So if you can make it, it's on September 7th, I think at around 10 o'clock.
I'll say, coming off a, late shift to do this on a fairly early morning, I think it is worth saying that what we do to us loses the shininess because we do it every day. So it feels routine to be able to see ourselves the way other people see us, which is that it's a little crazy, it's a little erratic, but boy, does it have really great and long-standing impact. So remember that as you walk into your next shift.
I think echoing that, but it wouldn't be my final word. It'll be Mel's final word, is what you do matters. And I think this eloquently displays that.
Excellent. Well, thank you all again. Truly appreciate your time. Many thanks.